introduce a friend of long standing and a very distinguished leader of American psychiatry. Charlie Nemeroff and I go back many, many years. And I've always admired his work. He really opened up the idea that the HPA axis was fundamentally involved with mental disorders. Were it not for him, we would not be as far along as we are in our understanding of stress, mental illness, and especially affective disorders. So it's a pleasure to introduce Charlie to you. Pleasure to have you here. And you see his title on the board here, along with his background is that he went to medical school in North Carolina and stayed there for a number of years. Went to Emory. Charlie has a knack for improving every place he touches. He has the academic Midas touch. And went to Emory. Became, under his leadership, an emerging, strong department. Now he's at University of Miami. And that department is on the rise now, as you will see. So it's a pleasure to introduce Charles.
So great to be here. Just a wonderful time with a number of friends last night at dinner, seeing Ming and Lou and Igor, Neil. So, and I have so many friends here. I went back and looked at my CV, and on September 8th, 1994, I gave Grand Rounds here. And very few of you were here then, although Murray, who I had breakfast with this morning, said he had been here a month then. And looking out, I see Barbara and a number of other luminaries who've been in this department for a long time. I want to, before I begin my presentation, make a couple of introductory comments. First about Lou. I've known Lou for 30 years, and I want to say a few things about him. One, he's built one of the most amazing departments of psychiatry in the United States, and for you young whippersnappers out there who don't realize it, with meager resources and the ability to recruit, Lou would have been a great salesperson. He managed to assemble a team of talent that ranged from alcohol and substance abuse, Mark Shuckett and his team, aging, Adela, PTSD, Murray, Neil Swerdlow's work, David Braff. I could go on and on. An education program, bar none, that Sid has led. Really, Lou is sort of the Nick Saban of psychiatry. My son played football at Alabama. I'm trying to recover from this awful loss. So I got a little PTSD. But I want you to understand about Dr. Judd. Without a doubt, he was the best NIMH director we ever had. And I've lived through all of them. And I have to tell you, he was a great NIMH director because he put himself aside, his own ego, for the betterment of the field and for the investigators. And he never, ever avoided a phone call. He never not looked at a situation that needed looking at. And he was always driven by the best science that was best for the field. And he was a mensch. He had relationships with people in a way that wasn't driven by malignant narcissism. You all know about malignant narcissism, okay? It was driven by a love for the field and being able to catapult psychiatry and mental health to where it needed to be. And my university president, Donna Shalala, interacted a lot with Lou during those years, and she speaks extremely highly of him. So you're very fortunate, very, very fortunate. And I feel sorry for the person who has to fill those shoes. Won't be a tough road to hoe. And on a personal level, Lou has been a stalwart friend to me through good times and bad. And that's important. And in the end, it's what really matters. So I'm going to talk to you about science and some work I've done over the last several years. But I just wanted you to know how fortunate you are. Sometimes we take things for granted in our leaders. And you guys, when you see Lou later today, give him a hug. Okay? Because he's out there fighting for you guys and gals. So, all right, I'll get off the soapbox here. So we have an ocean in Miami, and we have palm trees in Miami. I use this to recruit people from the Northeast around this time of year. That's about 10 minutes from my office in Key Biscayne. And I wanted to provide you with my research grants and my financial disclosures that are also on the website. So I'm largely going to give this presentation from a chronological point of view, largely directed to the young investigators about how one studies a problem, big or small, and how you can take that problem and with the help of people who are experts in various areas can actually get the task done or begin to address big problems. And for those of you who do clinical work, my recommendation is to keep a little series of Post-it notes in your pocket, and every time you have a clinical question for which there's no answer, just jot it down, because that's the basis for a whole bunch of new grant proposals, because there are lots of things we don't know. And so I've been blessed with a lot of fabulous people, and the best thing you can do as a chair or as a faculty member is to recognize talent in other people. So I've had a wonderful group of collaborators, and my job was to try to get them to be successful. So Carrie Ressler is a Howard Hughes investigator. Elizabeth Bender was just named the new director of the Max Planck Institute in Munich. She was my PhD student. She's the first woman ever named as a director of the Max Planck Institute. Very, very proud of her. She'll be at ACMP. Christine Heim was my fellow and junior faculty member as the chair of psychology in Berlin at the Charité. Andy Miller is an endowed chair at Emory, and Larry Young and Mike Owens were both professors. And I've got a team in Miami. Phil Harvey, many of you know, is the division head of psychology. Amanda Myers is our geneticist, trained at WashU, and my statistician. Never take your statistician for granted. And a psychologist that works with me, and my imaging collaborator is Clint Kells. So I've always been interested in mood and anxiety disorders clinically. I still have a pretty large practice. I see about 15 hours of patients a week, and I also cover the geriatric inpatient psychiatry unit 4 weeks a year, so I try not to be rusty. What we know about depression, in a nutshell, is that stress is really important. All of you know that. It precipitates depressive episodes in vulnerable individuals. I'm going to be focusing on early life stress. I try to convince you that this is one of the most important factors in vulnerability for mood and anxiety disorders. And as it turns out, genes account for a substantial amount of the risk. So that depression and anxiety disorders are the prototype gene-environment interaction disorders. That if you have early life trauma, as I'll tell you, coupled with certain genetic vulnerabilities, you have a high likelihood of developing a mood or anxiety disorder. And then, of course, what are the brain systems that are the substrates for this process? Those are the sort of important questions. And this sort of begs a look at all of medicine, including psychiatry, as we move forward. This is a graphic that the dean at Miami is a cardiologist and I recently published in an article on depression and heart disease, in which we view 21st century medicine moving away from where we all are which is where patients come to us and they're sick, they're psychotic, they're jaundiced, they're having trouble breathing, they have chest pain, and by the time we see them, they often have an impairment in organ integrity, whether it's brain, liver, heart, pancreas. What we'd like to do in all of medicine is to back up here where we begin to see patients at the tipping point before they ever have their first episode of PTSD or depression or psychosis, something Ming obviously has focused on for many years. And where the future is, obviously, is going to be here, and this is really what personalized medicine is about. It's the idea of being able to identify at-risk populations, either through genomics or perhaps imaging or other markers, and determine who's at risk so that we can actually prevent them from ever having their first episode. Last night, Igor and Grant said to me, we'd like to eliminate AIDS, and I said, and we'd like to eliminate suicide, and we'd like to eliminate psychosis. And the way to do that, obviously, is to identify who's at risk and to vaccinate them, or intercede, or do gene therapy, or stem cell therapy. This is where the future of medicine is, and we as psychiatrists need to be there. But on a more mundane level, what we need to begin to ask is, how is it that these disorders that we are focused on, bipolar disorder, schizophrenia, depression, PTSD, which have such a large genetic component to vulnerability, what is it about those genes that result in changes in cells, presumably neurons, that result in changes in circuits that we see on brain imaging studies that result in these phenotypes that we see here? And that's at the fundamental part of where psychiatry is today. Now, sadly, we have not learned a lot about risk factors for depression in the last 25 years. This slide was actually made 25 years ago, and it's about the same database. So we know that there's a genetic component for depression. You've had it before, you're likely to have it again. A lot of the studies Lou did following patients with mood disorders over time confirm that women are more vulnerable than men for mood and anxiety disorders. But we also know that early life stress in the form of loss of parents at an early age, child abuse and neglect, is associated with a marked increase in risk for mood and anxiety disorders, as is recent life stressors, like having a super right-wing governor in Florida is a major life stressor for us. He just turned down $40 million in Medicaid supplement from the federal government on general principle. That's our guy. You know who he is? Rick Scott. You know Rick Scott? It's the guy that, I know you're recording this, so I'm probably going to go to hell. Rick Scott said no low contendere 145 times when he was the head of HCA. Okay? That's all I have to say. Now, so talk a little bit about the biology of the stress system, and then the whole rest of the time I'm going to talk to you about early childhood trauma and what its consequence is. And the take-home message is that child abuse and neglect in the context of a developing brain has very persistent, long-lived sequelae that last for the lifetime of the individual. It leaves a scar, some people call it a limbic scar, but it leaves a cortical and limbic scar that has devastating consequences in terms of disease vulnerability, not only for mood and anxiety disorders, but also for cardiovascular disease and other medical disorders. So a very brief summary of the HPA axis, which you're all familiar with. CRF, which is a 41 amino acid peptide, is released from the hypothalamus. It causes the release of ACTH, which travels to from the pituitary, which travels to the adrenal cortex, releases cortisol, and then there's a feedback system. Cortisol will back up to the hippocampus, a very tightly controlled system. It's the major stress system. Within the brain, CRF also orchestrates the behavioral, the immune and the autonomic responses to stress. I'll remind you that our all very close friend, Wiley Vale at the Salk Institute, one of my very closest friends who died very tragically last year, was the discoverer of CRF. First found in crude form in 1955, but he took many, many years until he isolated it in 1981. So here's CRF containing neurons throughout the brain. Here's the hypothalamus, which activates the pituitary, but it's found in limbic areas that are known to regulate mood, particularly the central nucleus of the amygdala. It's found in every monoamine cell group, locus coeruleus, the dorsal raphe, and it's also found in the hippocampus and the cortex, and the receptors for it. So this is the major brain's representative of the stress axis. There are two types of receptors, CRF1 and CRF2 receptors. And Elizabeth Martin is sitting in the back of the room, was one of my PhD students at Emory. She's now working with Mark Geyer, and had been working with Wiley. This is one of her in situ hybridizations of CRF messenger RNA expression in the paraventricular nucleus of the hypothalamus. There's the third ventricle. So in early work that Lou alluded to, we demonstrated that corticotropin releasing factor, this brain HPA axis orchestra leader, was elevated in drug-free patients with major depression. But you'll notice in these 54 women that some of them have dramatically high CRF concentrations in spinal fluid, and others don't. You also notice no gender difference in the controls. It turns out that God did not give us tablets from Mount Sinai with DSM on them. So these are man-made diagnoses. All of you are familiar with all the controversies. So because PTSD is a stress-related syndrome, we looked at CRF concentrations in PTSD patients. These are patients that had a lumbar catheter in place in collaboration with Tom Giriciotti at the University of Cincinnati, and we were able to see marked increases in CRF and spinal fluid compared to normal controls, confirmed it more than one study. And in postmortem tissue studies, a variety of investigators have shown that CRF levels are elevated in depressed patients drug-free at death. This is the number of CRF neurons in the hypothalamus compared to controls, number of CRF neurons that co-localize with arginine vasopressin. So in this early work in depression, not focusing on early life trauma, we showed marked increases in CRF concentrations in spinal fluid and a downregulation of the CRF receptor in the frontal cortex in suicide victims. The idea being that you hypersecrete CRF chronically and you therefore downregulate the postsynaptic CRF receptor. And this was replicated in a phenomenal, elegant study in Canada by Zoe Morali and his colleagues here, just to show you, published in the Journal of Neuroscience, marked elevations in CRF levels throughout the cortex in suicide victims, and a downregulation in messenger RNA expression for the CRF1 receptor. So these findings together suggested that in some, many, maybe even most depressed patients, the CRF system in the brain was hyperactive. But I was running a mood disorders unit at Duke at the time, and this was a different era. So many of you, Sid, David, sitting here, Lou will remember our mean length of stay was 35 days. I know that's hard to believe. And we did the unthinkable. We would admit patients and we would actually take them off of all their medicine and watch them for a week to see what they were like. And it was amazing because we had time to talk to them also. And my patients kept telling me their life stories. After all, the reason we went into psychiatry was at least in part because we have this privilege of being able to hear people's life stories. And a number of them started telling me about their early life trauma, about physical abuse and sexual abuse and neglect. And I remember I was an assistant professor at Duke, and I had lunch with a very senior psychoanalyst. And I said to him, you know, David, his name was David, you know, my patients are telling me about this. And he said, oh, you're so inexperienced. He said, Freud made the same mistake. He thought those were real, but they're not real, they're fantasies. And you're so gullible, you believe it. And I thought to myself, God, am I that, like, naive? That they're lying to me? Nah, I didn't believe that. So I said to the patients, you know, a lot of people think that this stuff you're telling me is really fantasy. And they started bringing me their siblings, their medical records, and I came to believe that, you know, a lot of patients with mood disorders have histories of abuse. And I got dragged into this field that I had no expertise for in any way, shape, or form. And so I started looking at the literature, which was actually embarrassingly meager about how common child abuse is. And so it turns out that there has never been a national study to determine the prevalence rate of child abuse in the United States. No state wants to do it because nobody wants on their license plate to be called the child abuse state. So all of the data we have is suspect, but I'll show you in general what it's about. So this is sexual abuse, and I'll point out right up front that as clinicians we have a bias towards asking women about sexual abuse, and we don't ask men. And if you start asking men, you'll be horrified at how common sexual abuse of men are in their childhood. The two most common days for child abuse in the United States are Thanksgiving and July 4th, in case you're interested. Thanksgiving because big families get together, and July 4th because we all have pool parties, and neighbors prey on children in these settings. So it turns out that there are about, this data a little old, about 3.7 million reported cases of child abuse in the United States every year, and about 1.3 million are verified. But it turns out that this is a vast underestimate, because in most cases of child abuse and neglect are not reported. These are reports from emergency rooms, reports from school counselors, anonymous reports from departments of social services. But we know that the vast majority, and if you think about your patient population, you'll quickly realize that most of your patients do not report the abuse. So I'm going to quickly review for you some of the decent data that we have about the consequence of child abuse, just to convince you that it's linked to adult psychopathology. This is the best study done, guess where? In San Diego. 17,000 individuals, not patients, individuals in an HMO in San Diego were part of the ACE study, the Adverse Childhood Experiences Study. If you're interested, you ought to go to the CDC website. It's a wonderful resource. Robert Anda was an internist at the CDC. Was in the next building from me when I was in Atlanta, just how I became conversant with these data. I'm going to show you the suicide data as a proxy for the depression data. It's virtually identical. But the bottom line is, the question they asked is there a relationship between early life trauma and suicide attempts in adulthood? But it could have been depression, it could have been a variety of other things, which I'll give you the data for. And the bottom line is that if you had any one of these early life adverse events, such as physical, emotional, or sexual abuse, presence of substance abuse in the home, loss of a parent due to separation, divorce, or death, incarceration of a parent, domestic violence, any one of those increased your risk of suicide attempt 2 to 5-fold, but the effect was graded. So the more of these events you have, the higher the likelihood. And for those folks who had 7 individual events, like substance abuse, domestic violence 3 times, the risk of suicide attempt was 35%, an odds ratio of 31, which even Ming would say is a big number. Big number. We get excited with an odds ratio of 3. 31 is a big number. So they concluded that there was a graded relationship between early life trauma and risk of attempted suicide. And it turns out it also increases risk for inpatient hospitalization in psychiatry, depressive episodes, get this, cardiac mortality, myocardial infarction, asthma, obesity, and diabetes. And these data are all published. Another way to look at this is to look at internal medicine practice in Baltimore. 4 internal medicine practices that cut across socioeconomic class. And here, of these are all women, 1,931 of them, a quarter reported childhood or adolescent physical or sexual abuse. Think of that percentage. And of those women who reported abuse as children, but not as adults, they had more depression, anxiety, somatization, low self-esteem, more likely to abuse drugs and alcohol, attempt suicide, or be hospitalized. And Ken Kembler, in a study of 1,500 female twin pairs, was able to show that each of these squares impacted on the likelihood of a depressive episode, and they are obviously genetic factors, but then lack of perceived parental warmth, childhood parental loss, as well as lifetime trauma and more recent stressful events. So from these kinds of data, we developed a working model. And that model was that there are genetic contributions to disease vulnerability and environmental ones, but what we were talking about is this occurring in the context of a developing brain. Now, all of you know that the human brain develops very slowly. It doesn't actually mature until about age 24. Those of you who have teenage children know you've experienced it firsthand. And you know that the developing brain is vulnerable to lead toxicity, to infectious disease, to alcohol abuse, and it's very vulnerable to behavioral toxicity in the form of child abuse and neglect. So we developed this working model in which some genetic vulnerability, which is about 1/3 for major depression, 2/3 for bipolar disorder, coupled with the environment, in this case child abuse, would result in the road towards a psychiatric disorder. But that more recent trauma might further exacerbate the situation, and intervention may in fact raise the threshold to develop the disorder. And so my mentor at Chapel Hill was an old friend of Lou's, Maury Lipton, and his mentor was Julie Axelrod. And Julie Axelrod, who won the Nobel Prize in the early 1970s, always said to me, as sort of my grandfather academically, Charlie, you got to take a flyer, take a risk. So we had no data whatsoever, would never be funded. We thought, is it possible that CRF, changes in the CRF system, occur in response to child abuse and neglect, early life trauma, and that in fact is responsible for this increase in depression and anxiety, because we know that CRF, when injected into laboratory animals, produces a lot of the behavioral effects that we see in our patients. And so I'm going to show you a little bit of animal data, mostly clinical data. We used a model of maternal neglect. This is a rodent model. Here's one of the great moms of all time. Rodent moms, hundreds of thousands of papers written on their nursing and licking and grooming and retrieving of their pups. And here's dad, or not, because there is no paternal behavior in rats. All rat dads are deadbeat dads. Okay? They never bring home a check, ever. And sometimes they try to eat their pups, but they're not nice. So, you know, in that way, it has some shortcomings. So we took rats and we maternally deprived them from their moms for 3 hours a day between days 2 and 14. And then we tested them as adults to see if they were super sensitive to stress. And so this is the equivalent of a 5-year-old being neglected by their mom and now looking at a 25-year-old adult. And we gave them an innocuous stressor, which is blowing air in their face. Rats, like cats, don't like that. and they had an intravenous jugular catheter. Here are the normal animals showing ACTH and corticosteroid rise. Here are the rats that just had that 36 hours of maternal separation, now as adults, show the super sensitive ACTH and court response. And this lasts for the lifetime of the animal. So this early life trauma in the form of neglect leaves a permanent scar. And the reason is that the CRF system is jacked up. This is the locus ceruleus parabrachial area. In red are the rats that were maternally neglected. Now as adults, you see CRF messenger RNA expression is elevated here in the dead nucleus, in the central nucleus of the amygdala, and in the hypothalamus, and that this increase in gene expression shows a corresponding increase in CRF itself. And this lasts for the lifetime of the animal. Now, Elizabeth Martin, sitting in the back of the room, was able to do something that I could have never done, which is to use techniques of molecular biology to actually take a lentiviral vector and to insert the CRF gene and then inject it into the central nucleus of the amygdala of an adult animal, and then was able to show that these animals look exactly like the maternally deprived animals in being relatively anhedonic and having lots of anxiety and depression. So it looks like this increase in the central nucleus of the amygdala probably mediates that effect. The other thing I tell you about these animals that are maternally deprived, they're luscious. They love alcohol. Now, normal rats are much smarter than we are. They don't like alcohol. Given a choice between water and alcohol, look what happens. These rats, these were separated 15 minutes a day, which is a good thing for rats. And the normal controls, they prefer water. Look at the maternally deprived rats. They go right to alcohol and never stop drinking. Normally, you can't get a rat to drink alcohol. They also love cocaine. So early life trauma increases risk for alcohol and substance abuse as well. Now, you can partially reverse the effects of early life trauma by treating animals with an SSRI. And if you do that, you could reduce this abnormal stress response about 50%, but not all the way. So that's the ACTH response. And the reason is you can knock down that abnormal CRF gene expression, but not to normal. You see this reduction in these three brain areas. And we've also done this in non-human primates using a different stressor, and this lasts for the lifetime of the animals. These are bonnet macaques, and they just continue to hypersecrete CRF for their lifetime after early deprivation. So that's all the animal work. Now to show you our clinical studies, which you may find a little more exciting. So this was our first study that we published in JAMA. We wanted to see whether humans were like rodents. And we recruited women who had a history of child abuse with or without major depression, and women who were normal volunteers or who had depression without child abuse. So there were 4 groups of individuals. We admitted them to the GCRC where they stayed overnight, resting quietly. Their mean age was in their early 30s, as you can see here. They were a very highly educated group. And for those of you like Murray who study PTSD, I'm sure he'll agree with me that it's very hard to find patients who have major depression, early life trauma, who don't also have PTSD. In fact, 85% of our women with early life trauma and current major depression also fulfill the criteria for post-traumatic stress disorder. So when I get grant reviews back that say, oh, you're studying major depression and PTSD, you should study PTSD alone, or major depression alone, it makes me crazy. And Murray and I, we get those reviews all the time. So we admitted, as I said, the patients to the GCRC, and they stayed overnight, and then they were asked to come into a room like this with 3 really mean-looking men in white coats in the front of the room, had an indwelling catheter, and they were asked to give a 10-minute public address called the Trier Social Stress Test, and then they were told to subtract 17 from 4,000, serially, and we're told that no one had ever made an error yet. And the medical students' cortisol was up threefold with that, just telling them that. So what we found is one of those sort of nirvana moments. In blue are the women with early life trauma and major depression, and what you see is they show a phenomenal increase in ACTH and CORT in response to this simple laboratory stressor. So they look just like the rodents do with these histories of early life trauma. The other interesting finding here is that the patients with depression alone without early life trauma in green showed a completely normal ACTH and CORT response. So all those reports by Barney Carroll and others about abnormal cortisol secretion did not take into account early life trauma history, which turns out to be a big deal. These patients also show a profound tachycardia in response to the stressor, and this may be part of why they're so susceptible to heart disease. Topic for another day, maybe I'll get invited back and talk to you about depression and heart disease. These patients show a number of somatic symptoms, a reference to a variety of organ systems. They show achronic cyclic pelvic pain, lots of loss of energy. I'm going to talk to you a little later about some brain imaging findings that mirror some of this. So if you measure CRF in their spinal fluid, it's directly correlated with the level of emotional abuse or physical abuse. And it turns out, to our surprise, that that is true in both depressed patients and in our volunteers. It turns out that what drives CRF is not depression, it's early life experience. And whether you have depression or not, in every study we've now done, this is with Linda Carpenter at Brown, this is from our own data when I was at Emory, whether you're a normal volunteer or not, CRF concentrations are directly related to your history of abuse. And again, the Cincinnati group confirmed this finding in a group of 20 men with personality disorders where CRF levels were correlated. This was a collaboration that we published in the American Journal a few years ago. Were correlated with emotional neglect. Now, we finally got around to studying abused men. We had limited our studies to women, and then we took a group of men and looked at the most sensitive measure of HPA axis activity, which is to give dexamethasone to shut the axis off and then give CRH to stimulate it. And we found phenomenal hyperactivity in the depressed men with early life trauma compared to all the other groups. That's the ACTH results, and there's the cortisol results. This is profound hypersecretion, the kind of thing you see in Cushing's syndrome. Now, many of you know that there's been a big push to look at inflammation in depression. There's a whole wonderful emerging area that inflammation may be important in the biology of depression. So we took those men, did the Trier social stress test, and found remarkably that the most important inflammatory cytokine, interleukin-6, is wildly hyperactive in abused men with early life trauma. Look at this phenomenal increase in IL-6, and it correlated remarkably with the severity of their depression. Really remarkable compared to the matched controls. Now, there's been a lot of hoopla about oxytocin lately. And oxytocin, in many ways, is sort of the opposite of CRF. CRF is great for stress, but it's anxiogenic, it's depressogenic. And so if folks have too much CRF after early life trauma, what you'd like them to have is more oxytocin, which is responsible for maternal behavior. It's responsible for breastfeeding. It's responsible for parturition. It's responsible for social bonding. It's been called the intimacy hormone. I think there's been a lot of hype about this, but be that as it may, I had 1 ml of CSF left from our women's sample. And lo and behold, we found that unfortunately these folks have reduced availability of oxytocin. So they have a reduction in oxytocin, in emotional abuse, in physical abuse, in emotional neglect. And look at the correlation between oxytocin levels and spinal fluid and their childhood trauma questionnaire scores. So think about your patients with early life trauma. They have too much CRF, which makes them anxious and depressed, and too little oxytocin, which would help with emotional bonding and intimacy. Think about some patients that you know very well. So now I'm going to show you our newest data, which is very exciting. This was just published. No one had ever studied the cognitive consequences of early life stress. Why did I do that? Because I had a Post-it note in my lab coat which said, no one's ever studied cognitive function in people with early life trauma. And I'm thinking of all the borderlines that I've seen over the years. So we use the CANTAB, the Cambridge Standard Battery for Cognition, which is now free. It cost me $170,000 to get the license for this damn thing. Now it's available because I think the copyright ran out. But I'll just show you some of the findings. It turns out that patients that were abused and neglected showed real deficits in visual memory, in executive functioning, in spatial working memory. And those that were neglected, I'll get back to this later, showed more emotional processing and emotional inhibition deficits. And that sexual abuse was associated with very profound deficits in visual working memory, and as well as with executive functioning deficits. So I want you to think about your patients in this regard. Just on the neuropsych testing alone, I could separate out the patients who had abuse and neglect from those who had abuse from the normal controls, just on the basis of their nature of their early life trauma. So now let me tell you a little bit about the genetic side, because I couldn't not talk about genetics with Ming here and Murray here. We've done a fair amount of work in this area, largely with Carrie Wrestler and Elizabeth Bender. These are 500 African-American patients sitting in the waiting room of an internal medicine practice at Grady Hospital in Atlanta, waiting to be seen. A highly indigent population. You could see what their household monthly income is, a third between $0 and $250. Most of them were unemployed, 2/3, tough population. We measured their child trauma histories with the childhood trauma questionnaire, and not surprisingly, the more child abuse they had, the higher their Beck depression scores. We divided this up into 2 groups. So we had none to mild child abuse and moderate to severe child abuse. And then we did what Julie Axelrod told me to do, take a chance. So this is the CRF1 receptor genome. And each of those arrows is a SNP, is a variant of the CRF1 receptor. And the question is, do variants of the CRF1 receptor mediate the depressogenic effects of child abuse? It's a very simple hypothesis. We set the bar very high at a 0.01, and there were 3 SNPs that fell out as being mediating the depressogenic effects of child abuse. So these are the kinds of data that you'll see more and more of. And if you're not familiar with it, let me run it by you. Because it's really partly the way the field is going. So in the absence of child abuse, look at none to mild. These are 3 different SNPs of the CRF1 receptor, and these are the Beck depression scores. Notice in the absence of child abuse, with none to mild, depression scores do not vary as a function of genotype of the CRF1 receptor. But look what happens in the presence of child abuse. Now the differences are robust. So this SNP, and this SNP, and this SNP, tremendous vulnerability to depression, whereas these 3 SNPs are resilient SNPs. In the presence of child abuse, no depression. What if you have more than one of the vulnerability SNPs? You know, I mean, you don't pick your parents, right? Well, you develop haplotypes where you can be really protected. But this is who I'm hoping is flying my plane to Chicago, right? Like the guy who landed, that Sully guy. He obviously has a lot of resilience genes. I don't know that I want this guy to be flying my plane. Okay, but look at the vulnerability here by sheer luck if you have these SNPs. And this is only one, this is the CRF1 receptor. So we went on to look at other genes, candidate genes, and what we discovered was that some of them mediate vulnerability to PTSD, others mediate vulnerability to depression. The CRF1 polymorphism finding has been confirmed by Caspi and Terry Moffat at the Institute of Psychiatry, confirmed by Alec Roy in suicide in his population. This is the FKBP5 gene. So first we discovered that child abuse, something Murray has also confirmed, that child abuse couples with adult trauma to increase PTSD severity. So that's very clear. And we found the FKBP5 gene is a gene that is a co-chaperone protein that mediates the effects of cortisol on the glucocorticoid receptor. Here are these SNPs that are highly significant in predicting PTSD, and the same kind of findings that I mentioned to you earlier. But there's one difference, and this is this paper we just published in Nature Neuroscience. So one of the mysteries has been, how does a SNP mediate the effects of early life trauma? How does that happen? And in this study, we're able for the first time to show a SNP-specific epigenetic mechanism to mediate the effects of early life trauma. So there is a polymorphism of the FKBP5 gene that actually is affected by the epigenetic mechanism of demethylation, and you can see that only the risk allele shows this effect in relationship to the magnitude of childhood trauma. So this is the first demonstration that I'm aware of the epigenetic SNP interaction and mediate the effects of an environmental trauma. So, one of the things about being a mentor is you have to let your children go, and they have to develop their own persona, something Lou has been a master at. So here are now my academic children without me: Elizabeth Binder, Amanda Myers at Miami, Carrie Ressler. They've discovered another gene that mediates the effects of vulnerability to PTSD. This is the Fat One Receptor, and the reason this is important, this gene, is it only occurs in women. And this may be one of the reasons why women were more vulnerable. There's an estrogen receptive element on this gene, why women are more vulnerable than men. And this was published in Nature in an original sample, and then they replicated it in a second sample. And recently, Klaus Wellstedt, who I was talking to Lou about last night, I recruited from the Scripps, and Elizabeth and Carrie have published a paper in Science, Translational Medicine, where they found yet another gene, the opioid receptor like 1 gene, that also contributes to vulnerability to PTSD. I won't bore you with the details. What about imaging? I'm going to move very quickly. What about imaging? Here's the hippocampus. It's smaller in depression. Both our group and Murray's group have reported that early life trauma affects hippocampal size. These are that original cohort of patients I showed you. Only the depressed patients with early life trauma show the reduction in hippocampal size. The depressed women without early life trauma have a normal hippocampus. Now, my patients show me the way. So I have this cohort of patients that I've been following for 20 years, 25 years in some cases. And a lot of them have done very well. But one of the complaints the women have had over the years is to say to me, Dr. Nemeroff, I finally have a good relationship. I'm not depressed, but I'm dead below the waist. What do you mean you're dead below the waist? I'm numb. I wish I could have a good sexual relationship, but it's just not there. I love my partner. I'm pretty happy, and so I had this crazy idea. Is it possible that there's been a change in the somatosensory cortex that mediates sexual function in people with early life trauma? And the reason I thought about this was because of the famous London taxi cab driver paper in Nature. You all remember that paper, in which they looked at the hippocampus in London taxi drivers, and they had a bigger hippocampus than the controls. So I thought, well, if studying those massive maps in London would work to increase your hippocampal size, maybe early life trauma works in a different way. And of course, the Hubel and Weasel studies with the visual system. So we had 56 of our women, and we had MRIs on all of them. And so we decided to look at two areas in particular. We decided to look at the homunculus for the genital region, and then we also decided to look at areas in the anterior cingulate that mediate emotional processing. We divided the patients up into those who were sexually abused and those who were emotionally abused and neglected. And so what we found, remarkably, here's the genital region, Brodmann's area 3, and what we found was a phenomenal reduction in the cortical area that codes for the genital region in the women who were sexually abused, and we found a marked reduction in the anterior cingulate and parahippocampal gyrus in the women who were emotionally abused. So here's the data for Brodmann's area 3, the sexual abuse. This is the emotional abuse. This was just published on the American Journal of Psychiatry about 2 months ago. So this is the substrate, we think, for the symptoms the patients are presenting. Is it reversible or not? We don't know that yet, but it's pretty exciting. And I'm going to finish, because I want to be able to take questions. I'm going to skip over the functional imaging studies and mention, now I want to talk about treatment, because those of you who are seeing patients will want to know this. So the group at the Institute of Psychiatry in London have been interested in two issues. One, does early life trauma predict course of depression? And secondly, does it predict treatment outcome? And so the data is actually quite interesting, and this was recently published in the American Journal. What you're looking at is all the data here related to course. This would be no effect, and anything to the right is a worse course. You don't have to be a statistician to figure out that early life trauma is associated with a poorer response to both psychotherapy and pharmacotherapy. I think the psychotherapy data, this is course of illness, and here is the treatment outcomes. And I'm just about to writing a paper now with a very large 2,000 patient study called iSpot, in which we were able to show that early life trauma predicts poor response to venlafaxine and sertraline. So here's the pharmacotherapy data. Again, very poor response. We reported a better response to psychotherapy than pharmacotherapy in chronic depression with early life trauma. No one has tried to replicate those findings. So I'm going to skip that over. Just to say one thing about the study we did, and that is, for patients who are depressed 2 years or longer and are chronically depressed, there were 3 groups, antidepressant, psychotherapy, the combination. These are percentages. So I just want you to see that only 1/3 of the chronically depressed patients had no early life trauma. 2/3 did. So when you're seeing patients who've been depressed for a long time, particularly those who haven't responded to treatment, it's very likely that they sustained early life trauma. So here's where we are. We realize now that we could throw out the old nurture and nature arguments that were silly. We know that there are important hereditary contributions. There's a paper about to come out in the Journal of Clinical Psychiatry showing that patients with bipolar disorder with early life trauma have a 4-year earlier age of onset and a much worse course in terms of depression and suicide attempts. So I just wrote an editorial about that. So where are we? Well, you know, Freud was the first person to posit an important role for early life trauma in the pathogenesis of adult psychopathology. And then he sort of fell off the track and said, oh, no, that wasn't right. It was a fantasy. Obviously, he was right. So he gets a lot of credit. And then Eric Kandel, actually, that's not Eric. but it's his favorite subject, aplesia. Eric has given us a tremendous amount of information from that model system about the effects of learning and memory on gene expression. And so if you think about it, sort of the way I think the field is going is that genes obviously exert a considerable control over behavior, but behavior and social factors in the environment clearly modify the expression of genes and can be in a very long-lasting fashion. And I think we would all agree about that. I personally believe that psychotherapy is a biological treatment. And I think it's very likely that effective psychotherapy actually is effective by actually changing gene expression that changes the strength of synaptic connections in the brain. And now that we have imaging techniques, and we're talking about the connectome and diffusion tensor imaging, we're probably going to be able to demonstrate the effects of psychotherapy. Technologically, we have one major shortcoming, which is in the human brain, we could not yet visualize gene expression. This is a real problem for us, because what we'd really like to be able to do is to image patients and actually look at CRF gene expression, see if it's changing with the course of treatment as symptoms are ameliorated, and that would also lead to new potential targets. And I think what you'll discover is that not only psychotherapy, but non-somatic, non-pharmacologic somatic treatments and other, obviously, medications affect gene expression. So I'm going to stop here. I'm very grateful to you for being such a good audience. Thank you.